دكتورة عزة يعني the hero of this
Professor Amal.
the hero of Gaucher disease as well, locally and internationally.
Thank you very much. شكرا لحضرتك يا فندم. I'm going to present a case of lysosomal storage disorder in hiding behind something else. Okay, so the parents presented at the hematology clinic when the baby girl, she was 3 months old, because she had a progressive abdominal distension, she had pallor, recurrent fever, recurrent attacks of vomiting and diarrhea over the last month. The parents were first cousin parents. They were living outside the country. They had a similar affected son who died at the age of 1 month. The family history revealed also a maternal cousin, a girl, who died early in the first 3 months of age with a similar condition without molecular confirmation. So we have our patient, she's a female, her brother who died early at the age of 1 month, and the cousin who was a female child. When we examined this child, 3 months old, she had a high fever, severe failure to thrive. She was irritable but alert. She had severe pallor, no bleeding manifestations, huge hepatomegaly. If we think of a liver which is 6 centimeters below the costal margin in a baby who is about 4.5 to 5 kilograms, this is a huge liver, and a huge spleen, about 8 centimeters, and she had evidence of chest infection. So we went to the ABC, CBC was done. She was anemic, 6.9 grams per deciliter. Her retics was 2%. Total leukocytic and neutrophils were okay. She was mildly thrombocytopenic with a platelet count of 95,000. We looked at the blood film, لأن مهم جدا to look at the blood film. There was no abnormal cells. PT and PTT were slightly prolonged. So we looked to other system involvement. She was hypoalbuminemic. Her serum albumin was 2.2. Bilirubin was normal. ALT and AST were 2.5 to 3 times the normal values. The serum creat was normal as well as the blood urea, and she had hyponatremia. Her serum sodium was 130 milliequivalent per liter. And أحب حضراتكم to remember these data we are seeing in this patient. So this patient had an emergency admission. She received supportive therapy, including parenteral rehydration and packed red cell transfusion. And in the next morning, you want to do investigations. You want to do a bone marrow examination, serum ferritin, assessment of the beta-glucosidase sphingomyelinase in the peripheral leukocytes, plasma triglycerides, all of the above, or only 1, 2, and 3, or only 1, 2, and 4. وده سؤال متكرر, I believe إن أنتوا هتعرفوه. So can we vote? Okay. So we go to bone marrow examination. Okay, good, تمام. And the beta-glucosidase and sphingomyelinase, only one of the 6 who made the voting. Okay, so let's return back to the slide, please. The previous one. Okay, ahead. So it's okay. You are going to go to bone marrow exam. You have a patient having bicytopenia, hepatosplenomegaly. You go to bone marrow examination, you go to serum ferritin, you do triglycerides. They are very important because you should think about, in this patient having fever, splenomegaly, bicytopenia, failure to thrive, you should think of hemophagocytic lymphohistiocytosis. تمام. Why you don't do beta-glu and sphingomyelinase? Because she received blood transfusion yesterday. There should be at least 1 month before going to do this enzyme SE in the peripheral leukocytes. Her serum ferritin was 1,600 almost. Triglycerides were relatively elevated. Serum fibrinogen was borderline. And the bone marrow examination revealed no malignancy, no hemophagocytosis, and no storage cells. So let's look clinically, from the first time I have seen this patient clinically, I said, okay, she is having hemophagocytic lymphohistiocytosis. And then let's look to the HLH 2004 diagnostic criteria. It says you can diagnose HLH if you have a molecular diagnosis consistent with HLH, which is genetic and familial HLH, or you have 5 of the 8 criteria listed below, which is fever, splenomegaly, cytopenia affecting 2 of the 3 lineages, increased triglycerides more than 265 milligrams per deciliter and or low fibrinogen, hemophagocytosis in the bone marrow or spleen or the lymph nodes or the liver, low or absent natural killer cell activity, ferritin more than 500 nanograms per ml, or elevated soluble CD25, which is interleukin-2 receptor alpha. Let's look to our patient. We had fever, we had splenomegaly, we had bicytopenia, we had elevated triglycerides, we had a ferritin more than 500. So we have 5 of the 8 criteria suggestive of HLH, and in spite of that, we did also for her the soluble CD25, and it was also elevated. There are other data, when you find them, you say it is supportive of HLH, like the neurological manifestations, cerebromeningeal symptoms, lymph node enlargement, jaundice, edema, skin rash. Sometimes the skin rash looks like patients having histiocytosis. If the patient is elevated, hepatic enzymes is a supportive of HLH. Hypoalbuminemia is supportive of HLH. Hyponatremia also, and a disturbance of the low-density lipoprotein and the high-density lipoprotein. So you diagnose the patient as a possible HLH, and because of the history, we say it's most probably she's having familial HLH because of these data. And hemophagocytic lymphohistiocytosis is considered as a severe hyperinflammatory syndrome induced by aberrant activated macrophages and cytotoxic T cells. So what's the next step you are going to do? You are going to do molecular diagnosis for HLH gene predisposition. You are going to assess for viral or bacterial infection. You are going to do an immunological profile to exclude primary immune deficiency, or you are going to move straight forward to the treatment of HLH as soon as possible. Let's vote لو سمحتوا. Okay, and تمام, still there is. Thank you very much. هناخدهم point by point. Okay? I want the voting. It's okay, doctor. It's okay. First of all, whenever you have a diagnosis of HLH, it is a rapidly progressive lethal disease. You should start the treatment of HLH as long as you have evidence that this patient is having HLH. You are going to think that this patient is, you want to do genetics. Yes, go to genetics because of the positive family history, because if the patient is having genetic HLH, this patient will go to bone marrow transplantation. You are going to assess for viral or bacterial infection because HLH could be secondary to infection. And it could be secondary to a primary immune deficiency disorders or secondary immune deficiency disorders. Yes, slides لو سمحت. But the most important, you should go. Let's think it is primary or secondary. As I said, it could be primary genetic, mainly related to defects in the perforin granule-mediated pathway of cytotoxicity, or X-linked syndromes associated with HLH, X-linked lymphoproliferative syndromes. Or HLH can be secondary to infections, Epstein-Barr, HIV, cytomegalo, bacteria, parasites, fungi. خدوا زي ما انتوا عايزين TB, leishmania, and all the bacterial and the parasitic infections can be associated with HLH. في what's called malignancy associated HLH. Immunological disorders ممكن تعمل macrophage activation syndrome, ومحطوط كده other causes. Other causes post organ or stem cell transplantation, in metabolic disorders, in immune compromised primary or secondary or unrecognized. أنا حطيت لكم إيه highlighting على metabolic disorder. So our patient was diagnosed as hemophagocytic lymphohistiocytosis, most probably familial HLH, and we started treatment and we took samples for molecular diagnosis of familial HLH, and she started the HLH 2004 protocol with DEXA, Vipicid, cyclosporin, and intrathecal, and then in spite of the HLH treatment, the patient clinical condition was deteriorating. Progressive increase in organomegaly, recurrent diarrhea, which became a massive diarrhea, progressive anemia, thrombocytopenia, elevation of liver enzymes, prolongation of PT and PTT, and we were following the ferritin. The serum ferritin was increasing and reached values exceeding 30,000 nanograms per ml. It is well known in the values of 10,000 nanogram per ml, ferritin has a more than 95% sensitivity and specificity for being an HLH disease. So this patient, in spite of the treatment, she is having progressive HLH disease. So what further steps should be done? You should screen for infectious etiology again. You should intensify the HLH protocol. You plan to go تسرع بالبون transplantation. You are going to reassess for a secondary HLH, or you get calm and wait for the genetic results of familial HLH. Vote لو سمحتوا. It's okay. Let's take it one by one. A screen for infectious etiology is very good. غالبا الابشتاين بار والسي ام في يا اما بتبقى البريسيبيتيتنج فاكتور يا اما initially او sometimes they are precipitating factor of relapse in the patients. You are going to intensify the HLH protocol زي ما احنا عندنا عينه at the present time. ممكن نزود يعني there are other options like the JAK2 inhibitors, like the anakinra, like the rituximab in Epstein-Barr related virus-related HLH. You are going to reassess for a secondary HLH. شكرا. This is a very important point. وهنسرع في البون مارو transplantation. It is good. نبتدي نعمل matching if she is having a sibling who can be HLA matched. طبعا never to wait for genetic results for familial HLH. لكن let's see احنا ايه اللي حصل. السلايدز لو سمحت يا دكتور. يا شباب. Okay. So concerning infections were excluded by serological examination for the hepatotropic viruses and by blood cultures. And we got lucky. We got the genetic studies were negative for genetic familial HLH. So it is not a primary HLH. It is a secondary HLH. So we said, okay, let's reassess. Let's do the bone marrow. Now the bone marrow showed numerous lipid-laden giant histocytes, C-blue histocytes. Phagocytosis of intact and or damaged hematopoietic cells was rarely seen. أنا لو ال HLH very active هلاقي increased hemophagocytosis. It was not common لكن كان فيه cells, histocytes, laden with lipids. يبقى أنا بتكلم على إيه؟ بتكلم على عيان عنده lipid storage disease, and this HLH is secondary to the lipid storage disease. So we went to order beta-glucosidase assay, sphingomyelinase assay, molecular diagnosis for Niemann-Pick type C, other enzyme assay, or whole exome sequencing. Let's vote. Yes. So in all cases we should look للي احنا بنشوفه اكتر بيتا جلوكوسيداز اسي وسفينجوماليناز اسي. وخليني اقول لكم دايما it is always recommended when you have a patient بتفكر انه جوشيه اعمل البيتا جلوكوسيداز عشان الجوشيه واعمل السفينجوماليناز عشان البوسيبيليتي بتاعه الاي اس ام دي. So they are usually done in twin. اوكي ماشي مش هزعلك انا ما شفتش بتاع ما شفتش الفوتنج. اتس اوكي جود. لكن انا لو طلع عندي البيتا جلوكوسيداز اسي نورمال والسفينجوماليناز اسي نورمال اوكي كده هفكر برضه في نيمان تايب Niemann-Pick type C, I should go to molecular diagnosis of Niemann type C. Other enzyme SE or whole exome sequencing. خلينا نقول زي ما أنا قلت, she was not Niemann-Pick type C. She has normal beta glucosidase and sphingomyelinase, بس هي لسه عندها lipid laden histiocytes in the bone marrow. ابتدينا نفكر ايه هو اللايزوزومال storage disease اللي كان present in the first days of life بvomiting وdiarrhea وfailure to thrive وhepatosplenomegaly وانيميا وثرومبوسايتوبينيا وجوندس وفي histiocytes infiltrating the bone marrow and infiltrating the liver. And we found that there is a disease called Wolman disease, or lysosomal acid lipase deficiency, due to deficiency of the lysosomal acid lipase, which is encoded by the lipid gene. There is accumulation of cholesterol, esters, and triglycerides in the lysosome of most tissues, presents early. وخلينا نفتكر إن العيانة دي كان عندها failure to thrive، إن العيانة دي كانت جاية vomiting وdiarrhea in addition to the huge hepatosplenomegaly. الdiarrhea كان عمرنا ما شفنا diarrhea such severe. تمام؟ So the baby was investigated for the possibility of Wolman disease, and she proved to be homozygous for the mutation causing Wolman disease. Let's think Wolman disease is called lysosomal acid lipase deficiency. Could be in the severe form, in the homozygous state, or in the double heterozygous. They present in infancy with failure to thrive, diarrhea, hepatomegaly, liver dysfunction, and adrenal calcification. And the life expectancy without treatment is less than 4 months. خلينا احطكم طبعا this is not my patient لان احنا عملنا سونار للعيانه دي ما حدش قال لنا ان في حاجه في الادرينال، انما it is reported that these patients, because of insufficient free cholesterol available for steroidogenesis in the adrenals, they get adrenal insufficiency and they get calcification in the adrenals, which could be a clue. ولما اقول لكم adrenal insufficiency افكركم ان العيانه دي كان عندها vomiting وهايبوناتريميا، فpossibly it reflected adrenal insufficiency في العيانه دي. في form attenuated form of lysosomal acid lipase deficiency اسمه cholesterol ester storage disease. الانزيم موجود اللي اسمه lysosomal acid lipase موجود بس decreased, so they can present at a later age in childhood or adulthood. They have malabsorption, progressive cirrhosis, cardio, and cerebrovascular disease, and usually if they are not treatment, they die of these comorbidities of atherosclerosis, myocardial infarction, and liver failure. So we are going to broaden our mind and look للحاجات اللي احنا ما بنفكرش فيها، اللي لو فكرنا فيها we will find it. So our patient had Wolman disease complicated by secondary HLH. Wolman disease has a treatment and enzyme replacement therapy which was approved by the European Medical Agency and by the FDA in 2015. And this is our final diagnosis, secondary HLH complicating Wolman disease, and ليه HLH and Wolman disease. And in the literature في case reports كتير بتتكلم عن العيانين الولمان presenting as HLH. And there is a large body of evidence accumulating in the recent years suggesting a strong link ما بين الانفلاميشن والميتابوليزم and a possible causal association ما بين الولمان والHLH, suggesting ان pathophysiological role of the cholesterol ester induced inflammasome activation. In the deficiency there is an increased inflammation. خليني أنا أقول لكم إن lysosomal storage diseases مع storage of the abnormal lipids in the macrophages, this results in an inflammatory state. So, accumulation of cholesterol ester in the macrophages results in inflammatory activation in the macrophages, leading to secondary HLH. So, this case, together with the already known association between HLH and inborn errors of metabolism, suggests careful metabolic workup should be performed when facing to a pediatric patient with HLH, and I believe, thank you very much.